This one's called The Case for Cognitive Behavioral Models in the Treatment with Psychedelic States. So I think the way we'll start out is each of us on the panel, and I'll moderate, each of us on the panel will just take a couple minutes to introduce ourselves and describe our background and relationship to CBT and behavioral therapies and with psychedelics. So I'm Matt Johnson, I'm at Johns Hopkins. I've been working with psychedelics for about 15 years, and I've actually been using cognitive behavioral therapy as a therapeutic backdrop to tobacco smoking cessation therapy with psilocybin for about 10 years. And my original, and still I would say foundational, scientific lens is that of radical behaviorism associated with B.F. Skinner, although I also like to use other models and think broadly. So I'd like to pass on the mic to Ingmar, and if you want to give us a bit about your background and orientation.
Sure. So this is a conversation that I've been looking to have for about 5 or 6 years. We'll see. And you might have noticed I was on another panel, healers versus therapists. And this, at least the description sounds like it's CBT versus depth psychology. So I think the organizers want me to get into a fight, and so that's what I'm going to try to do here. Although my orientation is primarily psychoanalytic, but I was trained in CBT. Actually, one of my primary mentors, Jeremy Safran, was originally trained in CBT and then became more of a psychoanalyst. But in my work, I blend CBT, mindfulness, psychodynamic ways of thinking, even to some degree transpersonal ways of thinking. And primarily this is it's part of the integrative school, so integrative harm reduction psychotherapy is my primary orientation.
Hello, my name is Ansgar Rougemont-Bücking. I'm working in Switzerland. I'm an EMDR therapist, I'm an addiction specialist, and I'm working with, at the moment, doing a research program at the University in Fribourg for burnout and depression. And my interest is to wonder, well, avoidance of what is difficult and what is painful is the central element of what we try to bring to our patients. And we think that psychedelics might be a very convenient tool to do this very efficiently. But I also would like to remind who we think we are, that we do this better than all the other colleagues. Because this is what patients are told repeatedly throughout their career. You have to face the difficult things, you have to go into it, you have to feel the pain. We are not the only one telling them this. They have heard this so many times, and they have been disappointed so many times, because they tried hard and hard and hard, and many times they were re-traumatized in doing that. So we have to be very careful if we say, we have a powerful tool to show you the trauma. Are we sure that we're not re-traumatizing our patients with that? And what is the most important tool to bring the patient into this exposure? I think it's the therapeutic relationship. We really have to work hard on therapeutic alliance. This is, in my opinion, the most important tool we have to develop.
So my name is Max Wolff. I'm a cognitive-behavioral therapist and an addiction researcher at University of Dresden. I'm also involved in the Mind Foundation, in the Science Committee, and I'm also involved in the hopefully soon upcoming psilocybin study that we're preparing together with our colleagues from Mannheim and Charité Berlin. But maybe I can start with a small story. So, yesterday Rosalind Watts was talking about the therapy program that's currently being used in London. And that therapy program is based on ACT, or is inspired on ACT, acceptance and commitment therapy, what Milan Scheidegger was also talking about. And as you have seen, there is a good fit between ACT and psychedelic therapy. And I invited Steve Hayes to come to this conference. Steve Hayes is the founder of ACT, the inventor of ACT. And this was in the beginning of this year, and I wrote to him, "Dear Dr. Hayes, we have this conference coming up, and I don't know if you're aware of it, but there is a certain synergy between ACT and psychedelic states." And of course he was aware of it. So Steve Hayes was born in San Francisco, and he was a young man in the late 60s. and he works at the University of Reno in Nevada, so he can probably see the Burning Man from his house. But unfortunately, he couldn't come because he has a book coming out last week. But he was aware of it, and he pointed me towards the upcoming JCBS special, the Journal of Contextual Behavioral Science. They have a special issue coming up on contextual behaviorism and psychedelics. And I do believe that this will get a lot of people who have not been aware of this potential synergy in cognitive behavioral therapy, interested in psychedelic states and in psychedelic therapy.
Yeah, thank you. So maybe we'll jump into that kind of a broad discussion of appropriate theoretical orientations for psychedelic therapy that Ingmar alluded to. So just to kind of orient you, cognitive behavioral therapy is sort of considered the second wave of behavioral therapy, the first being just your basic understanding of reinforcement and punishment, the role of context. The cognitive behavioral therapy movement incorporated more, obviously, cognitive understanding into that framework and information processing, looking at thoughts themselves as behaviors that can mediate overtly observable behavior. And then third wave, behaviorism, which I think we've already referred to, is referring to this next evolution where modalities such as mindfulness are incorporated, and themes that one could label as spirituality. So some of the empirically supported models that fall into this category are things like dialectic behavioral therapy or mindfulness-based cognitive therapy. So what are our broad thoughts, I'm asking the rest of the panel, on the theoretical model that really fits best? And of course, we have this backdrop of, in the heyday of psychedelic therapy, the psychoanalytic and psychodynamic tradition was predominant, and that was often used as an explanation for the subjective phenomena that were experienced during psychedelic states. So what about this idea versus modern behavioral therapies, cognitive behavioral therapy, and third wave therapies versus psychoanalysis versus any other theoretical orientation?
Sorry, if it's okay if I go first, because I don't know if anyone else here is going to do it, but it would be helpful to define also what psychodynamic thinking is. We've heard what cognitive behavioral is, and there's a lot there to talk about, and one of the big critiques of psychodynamic or psychoanalytic thinking is that it can be very impenetrable because there's so much and it's so written in such a complicated way. But one of the central tenets of this form of conceptualization is that there are things that are outside of our awareness that we push away, sometimes intentionally or unintentionally, because we are uncomfortable to be aware of them. I mean, that is sort of one of the ideas of Freud's writings in the 1920s, right? That we'd rather avoid things that are uncomfortable, and he looked at sort of certain instincts or drives that we have. And so, I guess in that way, it doesn't sound so dissimilar from some of the move from the second wave of CBT to the third wave of CBT. One of the kind of dynamic critiques of the second wave of CBT was that what CBT did in part was strengthen the defenses. So in dynamic thinking, when you put energy or push away things or avoid them, what you're doing is you are strengthening psychological defenses. And those defenses, those defense mechanisms, can take the form of symptoms. And so one critique of the second wave of CBT was, well, you're helping people, but what you're doing is you're helping them strengthen those defenses and get more control. And my understanding of ACT, which by the way I love, somebody gifted me Stephen Hayes' book, which I started to read, is that it was a move right away from this idea of trying to control things and rather accept those things. So maybe I'll pass it on to one of you too.
Maybe I can say something to that. I mean, I'm also a big fan of ACT, but on the other hand, I don't really think that ACT and second wave CBT are so different. They are a bit different, of course, but I think at the core of both of them is changing beliefs, whether it be the content of beliefs or our relationship to beliefs. And, well, if you look at current theories of acute psychedelic drug effects, then, well, it's belief relaxation. It's it's helping us to become less confident in the beliefs we have, and that's what we also try as cognitive behavioral therapists. No matter if we're second or third wave therapists, we always try to do that.
I would like to say, I'm wondering where the idea or the notion of avoidance comes from. I know that resistance and defense are terms developed by psychoanalysis, and they are very widespread in our thinking, of clinical reasoning and thinking. And I'm wondering if there's not some judgment in these terms. There's someone resisting, someone does not want to see, someone does not want to get better, someone has an intention, a covered intention somewhere, and we have to work on that. So there's the idea of will, there's a will problem. And to what I have learned from my trauma patients, it's just the incapacity of the system to adapt to something that is too strong. So I think the shift we have from the conceptions of older approaches of the last century towards what we try to do today is to acknowledge that we have all brains that can adapt, but sometimes the adaptive capacities are overcharged, and we should no longer talk about defense or resistance in terms of this. Something has to do with the will of the person. It's just from the system that it's not able to do so.
Yeah, I actually completely agree, and I don't use the word resistance, and I think, because not only, I want to add to what you're saying, it can actually be very stigmatizing to the person. It's basically saying you are not, you're not doing enough, or that it's just something that there's something in a deficit in you. On the other hand, to also bring in this idea that people are also conflicted, so sometimes it's also difficult because my background is in substance use treatment, and it's astonishing that people can both really they're ambivalent, right? A lot of work around addiction is working around that ambivalence. So people can have strong motivations in opposite directions. I have actually, could I ask a question? So there's, to both of you, there's, again, alluding to the description of the paragraph, and I was thinking about this topic. I was wondering, does ACT become a depth psychology when you introduce psychedelics? And what made me think about that was actually Rosalind Watts's talk, right? Because the model, which is a beautiful model, which I think is very useful, is that you go into the ocean and then you find the pearl. And depth being metaphorical for going into a place, sort of, I don't like to use the word unconscious per se, but going into a place where we don't typically occupy, a state that we don't typically occupy, to access something that we sort of know is somehow true, right? Because when we go there and we find it, we're like, right, this is familiar to me, but somehow isn't fully known. So that's, I don't know if you want to take that.
As you wish. I'm not sure if I'm really responding to your question. What I like ACT, I'm also practicing it and developing it in Fribourg, but I sometimes have the impression that it puts too much responsibility on the individual, and also like the mindfulness, all the mindfulness therapies, we teach the individual, you are the one you have to to develop and to do something, but we totally omit that there's a framework around this that might also have to adapt to this knowledge, this awareness. So I'm sometimes debative about how far will ACT be used, like the mindfulness techniques, just to put another layer of self-responsibility of the individual instead of creating a greater awareness of the system in which all we involving as individuals. So this is a wondering I have personally.
Well, yeah, I was just going to say in response to what you were saying, that it's yeah, I can see a point there about, you know, well, on the one hand, I could see a role in using the language of agency, but at the same time, along with what you're saying, we do know that, you know, guilt can be problematic. And so, for example, in smoking cessation and in other forms of substance use, if one of the things one can train someone on, and from a cognitive-behavioral perspective, is the abstinence violation effect. In other words, if you've quit smoking a week ago and you screw up and you have one, common pad research shows that if you have a lot of guilt over that and really beat yourself up, that's a good recipe for going and buying a full pack of cigarettes. But if you just stop, you know, get rid of the judgment, self-judgment, the guilt, and you just say, you know what, this was a case of learning. Now I've learned about another weak point, what this circumstance was that led to, you know, this slip, not a failure, but a slip. Now I'm even better positioned to be more resilient in a similar context next time. So, you know, there's an empirical basis for that. So I can see, you know, what your description is, and how maybe certain languages can lead the client to have more self-judgment. Did you have thoughts on this general topic?
No important
Max?
ones.
That's it. And in terms of the, psychedelics leading ACT to become more like depth psychology, that's an interesting thought. That got me thinking about, just in terms of basic operant conditioning or the effects of environmental consequences on behavior. I mean, this is essentially like evolution by natural selection. I mean, this is basic foundational behaviorism. There's variability. We emit variability in our behavior. We emit variability in our thoughts. And the greater that variability, the more potential consequences in the environment we're exposed to. And then it's those consequences in the environment, and also I would argue consequences of certain thoughts which might lead to other thoughts and potentially behaviors that then further drive behavior and thought. So in that sense, from just a very, not even second or third wave, but first wave behaviorism perspective, psychedelics, you can call it, you know, the cognitive flexibility or inducing a plastic state, you're increasing variability. I mean, you can describe this cognitively in terms of increasing perspective, or behaviorally in terms of this broader range of behaviors that the person may engage in after. And this is just theoretical and not empirical at this point, but the way I tend to think about it is that the psychedelics don't necessarily lead you to some truth. They broaden the lens. You know, it's the non-specific amplifier description that's been used. And with that, that's the increased flexibility, the plasticity. But given that plasticity or that increased magnification, everything else in your history, everything you've learned throughout your life, all the schemas are brought to bear in identifying. Sometimes it's obvious under that enhanced, expanded state, like, of course this is the direction, of course this is right. And it's not the psychedelic that inherently leads you there. It's other aspects that are in your history and in your genetics and everything else in your constitution that help you identify that as the optimal path So anyway, yeah, thoughts?
Yeah, I'd just like to riff on that, and I'm going to argue now against myself about psychodynamic. One of the I think, and on the topic of behavior, right? I think one of the critiques that's totally fair is that there may have not been enough focus on behavior in psychodynamic models and thinking, and I think any modern psychodynamic practitioner needs to also be aware of behavior. And so as an integration, so in doing psychedelic integration, which I'll be talking about later in the afternoon, post coming into contact with a broadened perspective or cognitive flexibility or the truth, action is actually really, really important. And so I think that that's where actually behavior is key, that you don't just realize something, but there's actually this reinforcement process that occurs when there's behavior change.
Yeah, I would like to add something to that, to first wave behaviorism and psychedelic therapy. So I think it's a very obvious thing, but probably a lot of people don't really think about it that way. But in psychedelic therapy, although it looks very passive from the outside, the patient is lying down, wearing eye shades and usually not moving so much. Behavior still takes place, internal behavior. People are doing a lot in this psychedelic state. They move towards things and they move away from things, and they look at things and they look away from other things. And these behaviors have consequences, and they are being rewarded or punished. So there is a lot of conditioning, operant conditioning going on in psychedelic therapy. And this kind of operant conditioning does not always necessarily follow the same rules as under in normal waking states. So one idea that I will be presenting later is that the psychedelic state actually punishes avoidance. I think we all agree on that. So I think it's very obvious. Many people don't really think about it that way, but during the psychedelic state, we very often have a transient phase where avoidance behaviors, internal avoidance behaviors are being punished, and that motivates people a lot for acceptance. And this in turn enables exposure treatment of a kind that is impossible in normal waking states.
What I would like to add concerning what was just said, if we talk about behavior, you have to be aware that we are talking about the body. And I think behavior means that we implicate the body's experience, and this is something new and important for third wave and psychedelic experience, that we are now taking account of the body. And this is very important because most of the talking therapy is too cognitive, too neurocortical, and we do not reach to the bottom of the problem. And that's really, I think that's a more important message, that we now know that if we really want to achieve a significant change, we have to go deeper, we have to go to the bodily experience. And we can reach to that not only by substances, but also by other therapies. And I think it's also very important that we train people for bodily treatment, touching, movement, respiration, because the body is part of the whole system, and we really should take account of this.
I completely agree. And I also am a therapist in the MAPS trials, and there we also focus on the body experiencing and encourage a person to notice what's going on in their body, and also using touch to bring a person's awareness to the body. I have a question for you, which is, I agree with what you presented, that the psychedelic experience can be extremely behavioral, and that there is punishment and reinforcement. But so far, I presume that all of the science that has been done, say particularly around psilocybin, has been with the participant sort of engaging in that in a kind of spontaneous way. And I've always wondered what would the reaction be if the behavioral or the cognitive behavioral intervention during the psychedelic experience was more directive. So something like prolonged exposure with a script or CPT or something like that, where, and I wonder how a person would react if they were sort of being told what they should do. There's something going on with the person doing it themselves, and I'm wondering if either of you have any thoughts.
Okay, so I understand you're asking about what would happen if we change the therapeutic model so that it's not an introspective or unguided experience anymore, but actually interventions happen during.
And go ahead.
I mean, I just say, the reason why I say this is because it seems like a logical next step. I mean, I think we in this community kind of have an understanding of what it's like. But if I could see somebody who's not really familiar with psychedelics in the CBT community saying, this is a great idea. We'll get them into this state, and then we'll sort of make them to do these following steps and combine,
Yeah, right. I mean, I'm now imagining a spider phobic in psychedelic therapy, and you give them a tarantula. I'm not sure what the ethics committees would say to that. But I mean, I think it's certainly interesting. I think we should try that, perhaps not with spider phobia, but with some other things. But I wonder if it's actually necessary. I think the internal world is maybe just enough, and maybe just leaving the patients doing it for themselves and motivating themselves for it also, because this is also an autonomous process that is going on. I think that may actually already be a perfect solution. But I think it's totally worthwhile also going the other way and trying exposure treatment in psychedelic therapy, going up high buildings and stuff like that. Yeah.
And this is also relevant to one of our audience questions, which essentially gets at what has been called psycholytic therapy, which was one of the dominant traditions in the early days, particularly so here in Europe. The idea of using lower doses, which are not the high doses that are being used in most of the modern therapeutic psychedelic research. And so that, I mean, I see it all as a very empirical question. And I mean, you gave the examples of how you deal with phobia with exposure therapy, but you could, theoretically use any model. I mean, back in the day during psycholytic therapy, it was, of course, it was psychoanalysis during a low dose of LSD, because it was the 1950s and then the 1960s, and that was the model then. But you could use CBT with a low dose. I see it as all an empirical question. I think all of the above needs to be, tested. Still so much in psychedelic therapy with the high dose and the eye shades and the internal focus and the music it's a method that seems to work really good, but the pieces of it virtually have no empirical foundation. It was something that looks to trace back to Al Hubbard in the 1950s, and he introduced it to the scientists in Saskatchewan, and it took off from there. And it seems to work, but there really have been no trials comparing it systematically to other methods, to psycholytic therapy, to, regardless, even controlling for dose, and no attempt to decouple the particular components. Maybe we can chat about, so that was essentially, I think, got into one of the audience questions. How about a pretty meaty one here? This will get fun. If a patient has a supernatural, quote unquote, or mystical, quote unquote, experience during a session, should the therapist encourage naturalistic interpretations during the integration stage, or should this depend on how adaptive the beliefs appear to be to the subject given their history and cultural situation? And another question is so similar, I just want to go ahead and read it as well. How do you draw a line between the supernatural and the rational world in regard to the psychedelic medicine? Should psychedelic therapists learn things like entity extraction and cleansing of heavy energies in the therapist office? I mean, I'll make one definitional, clarification here. At least the construct of mystical that we use, even though it has a connotation, which I think is a weakness, a connotation of supernatural, it actually is explicitly divorced in terms of the items asked about any supernatural belief. It really is getting it to a psychological state. But nonetheless, what do you think about these other, I mean, if a participant talks about plant spirits or entities or chakras or any of these many frameworks that, you're going to come across when you talk to folks about psychedelics, coming from a mainstream a trained tradition, how do we deal with that? Should we be introducing any of those concepts?
Well, I would just intuitively suggest that we let help the person develop what is giving best sense and positive sense to him. This might be going more into spiritual or supernatural ideas, or maybe not. Because we all sometimes I have the impression we always think if we go more into supernatural experiences or spiritual, this might be necessarily a very good thing, but maybe it's not. I know many patients that are scared to death and they want to get other explanations for what they're living in their lives. And I think we just should listen to the patient and allow him to develop the vision and the interpretation of his experience that is fitting best, and it's making him feeling good about his experience. So completely open, but the patient or the person is the one who has to discover by himself. But we should, I think, be careful about just saying the more it is spiritual, the more it is supernatural, the more it is bizarre, the better it is, because I don't believe that.
Regarding mystical experiences, I do believe that it's certainly important for patients to talk about the meaning of these experiences. But as a cognitive behavioral therapist, my first question to the patient would probably not be about the meaning of it, but about how did they get there? What sorts of behaviors led to it, and what sorts of behaviors would have impeded it? You know, if you think of how mystical experiences, ego dissolution, what is behind it? It is a disintegration of self-models, right? One could assume that as long as one engages in certain internal avoidance behaviors, such as worrying, what is happening to me? How can I end this? These are self-referential thoughts. And I think it's plausible to assume that these would sustain the self-model more than perhaps if you just let go and let the experience happen. So I think there is a lot to learn from mystical experiences that does not necessarily have to do with the meaning of those experiences, but with how patients got there. And we can get a lot of valuable stuff out of that.
I'm going to jump into the one that people are avoiding, the energy extraction. I would say, or the entity extraction. I would say know your limits as a therapist, right? So I will speak for myself. That's not something that I do or know how to do. But if I was working with somebody who really thought that was what they needed, I would hope that they could find somebody who could do that. And then on another level, I might be working with somebody in integration who is bringing in a supernatural or mystical experience that I don't entirely, is not consistent with my worldview. And in that point, being aware of my countertransference, or in plain speak, my reactions and my feelings to the patient or client or what they're saying, I have to be aware of what reaction. This is where mindfulness comes in. Being aware of how I'm feeling about this, and making sure that my reaction is not going to be, even if it's not even verbal, that my therapeutic stance doesn't shift in a way that's detrimental. So in line with what you're saying, detrimental to the person who I'm working with. I can still support somebody's growth and their healing without not necessarily having to believe what they believe. But if it does get to this point where their belief is becoming harmful to themselves, I do think as a mental health provider, at least, I have some responsibility to help them not necessarily change their worldview, but to become aware of what are the possible consequences or implications of their belief. Like if they believe they can fly, I don't want them leaving my office thinking that they can fly. I mean, to make it that's very simplistic, but it illustrates my point. Yeah.
I agree with so much of what's been said in response to this. I mean, my thought is, it's very similar to Ingmar's. You have to be aware of your foundation, and if you're a licensed clinician and you're traditionally trained, I mean, you have hopefully an empirically founded basis, and you're going to not introduce frameworks that that don't have an empirical basis and you're not trained in. And I sort of believe it's very important to not introduce these kind of non-empirical frameworks, but at the same time completely be open with that clinical radar up that Ingmar described. So, if the client is a Christian and is into Jesus, great. You talk about Jesus opening your heart during the psilocybin session. Let's talk Jesus. If it's Buddha, if it's plant spirits, if it's chakras, like, bring it on. But I personally feel that it's really important to make sure not to introduce any of these frameworks, impose them. And I differ a little bit from, or more than a little bit, from others in our broader group at Hopkins. For example, in our smoking cessation research, in our shared session room, I pull out the statues of the Buddha and other religious iconography. We invite all participants to bring in photos, not just invite, we say you should do this. Bring in photos of your life and your loved ones and meaningful things. And if the Buddha is meaningful to you, please bring it in. But, and in the spirit of mainstreaming this stuff, if you're a traditional Christian and the Buddha is not consistent with your framework, it's not my job to be, introducing, nor is it my job to be introducing chakras or plant spirits. But I can, I can roll with any of that if you bring it up. But always with that clinical radar, it's one thing if someone says Jesus spoke to their heart, it's quite another if they said Jesus told them through the neighbor's dog to harm somebody. So, and sometimes there's a gray area there that requires experience and wisdom. Any other, we've got a minute left. Any other final thoughts on anything we've talked about here?
Yeah, well, let me just add to that. I think it was already said, but I believe spiritual beliefs should not be treated different from all other kinds of beliefs, from at least by therapists. By philosophers, maybe they should, but by therapists, from a therapeutic perspective, at least in cognitive behavioral therapy, we would always, regardless what kind of thought or belief we are dealing with, we would always look if it's a functional belief, if it works for the patient, or if it leads to problems. Yeah, that would be my take on that.
Okay, thank you very much. Thanks to our panelists, please.